Hey everyone, this is the second of two videos on scrotal pathologies. This video will be pretty long, so I'll try to get through it as quick as possible. Watch it at 1.5, 2 times speed if you want to get through it quicker. It'll be covering hydroceles, variceles, testicular torsion, and testes cancer. All very important concepts. Now that we have discussed the basic approach to physical exam of scrotal pathologies, it is helpful to understand their classifications. Scrotal pathologies are divided into extratesticular lesions involving layers around the testicle, the epididymis, spermatocord, and appendages of testicle, or intratesticular lesions which involve the testicle specifically, which are more worrisome for malignancy. As mentioned in the previous video, when assessing the patient, always keep these areas in mind to create a clinical context for your patient, such as the patient's age, onset being acute or chronic, painful, is it intra or extratesticular, does it transilluminate when you shine a light at the condition, and was your analysis done, what were any findings? So with the basics covered, let's start with extratesticular lesions. Common extratesticular lesions are hydrocele, varicele, spermatocele, epididymitis, and testicular torsion. While these conditions are often benign, they may need urgent assessment. Our first scrotal condition will be hydrocele. In terms of pathophysiology, most hydroceles have an idiopathic etiology. It is a collection of peritoneal fluid between two layers, the parietal and visceral layer of the tunica vaginalis, which surround the testes and the spermatocord, and derives from the peritoneal lining of the abdomen. Like the peritoneal lining, the tunica vaginalis is mesothelium, which produces and removes fluid, so hydroceles are thought to arise when there is an imbalance of these functions. Moreover, symptoms of pain and disability generally increase with the size of the mass. There are different types of hydroceles, communicating versus non-communicating hydroceles. Communicating hydroceles develop as a result of failure of processus vaginalis to close during development, leading to patency, thereby connecting the peritoneum and the hydrocele. The passage of peritoneal fluid mixes freely with hydrocele fluid. Communicating hydroceles are most commonly found in infancy. On the other hand, non-communicating hydroceles means there is no communication between the hydrocele and the peritoneum. Also note, there are other types of hydroceles, like reactive hydroceles, which occur in response to a testicular neoplasm or with acute inflammatory scrotal condition, such as epididymitis, torsion, or appendiceal testicular torsion. There are also filarial hydroceles arising from filariasis, but these are associated with patients from endemic tropic region. Here you can see a communicating hydrocele with its defining feature, the patent processus vaginalis. These hydroceles are gravity dependent, meaning they usually disappear in the recumbent position. As they derive from developmental anomalies, they present with herniation of abdominal contents and indirect hernia through the processus vaginalis. Surgical repair is advised in these cases. Here you can see a non-communicating hydrocele. There is no patent processus vaginalis. Instead, you can see a collection of fluid between the layers of the tunica vaginalis distal to the fused processus vaginalis, the cause of which are commonly idiopathic. On history, patients often complain of a feeling of fullness in the scrotum or enlargement of the scrotum affecting daily life. Hydroceles are one of the commonest extratesticular conditions. It is a benign scrotal mass present in 1% of all men. The patients are often under 1 year of age or above 40. You want to ask them where they're from, or if they've traveled to a tropical region where filariasis is more common. On physical exam, some of the special findings can include a firm, large mass with the associated testicle usually not palpable, the ability to palpate above the mass within the scrotum, and transillumination when shining a light through the scrotum at the swelling, which indicates that the lesion is fluid-filled. Diagnostic tests like urinalysis have results that are usually negative. If the clinical picture is unclear after performing a physical exam, use a scrotal ultrasound. Typically, hydroceles don't require treatment as they resolve spontaneously, but surgical intervention can help if it fails to resolve under observation, or if the lesion is large, painful, irritating, or socially embarrassing. Intervention is prompted if underlying pathology is suspected, like torsion, infection, tumor, or if there's an inability to differentiate the swelling from an inguinal hernia. The most common surgical intervention is excision of the hydrocele sac. Percutaneous aspiration of hydrocele fluid can also be done if combined with an agent that scleroses the sac, preventing fluid to reaccumulate. However, there is a low incidence of reactive orchitis epididymitis, which can make open surgery more difficult due to inflammatory adhesions developing between the hydrocele sac and the scrotal contents. The next extratesticular lesion we will look at is varicocele. A varicocele describes the pampiniform plexus and spermatic veins that are dilated and tortuous surrounding the spermatic cord, which looks superficially like a bag of worms. Importantly, varicosities usually occur on the left hemiscrotum and may grow over time. It is gravity mediated, meaning it looks worse when standing and better with recumbency. If the varicocele does not collapse when the patient is supine, suspect a left spermatic vein obstruction within the abdomen. Also, varicocele may be associated with infertility, although this association is weak. Varicoceles are another common extratesticular lesion, occurring in about 15 to 20% of postpubertal men. Classic history findings of varicoceles are patients are typically above 12 years of age, as varicoceles generally appear after puberty. Patients typically don't have pain, but if they do, they may present with dull, aching, usually left-sided scrotal pain, exacerbated by standing and alleviated by recumbency. The condition may be chronic in nature, and there may be signs of testicular atrophy due to apoptosis, which may be triggered by slightly increased scrotal temperature. In terms of anatomy, recall the countercurrent mechanism of the pampiniform plexus surrounding the testicular artery. As the pampiniform plexus and other spermatic veins dilate, blood returning to the heart flows less quickly, which means inefficient cooling of the body-warm testicular artery, resulting in testes overheating. Varicoceles are classified into the following grades. Grade 1 are small, which is palpable only on Valsalva maneuver, which increases intra-abdominal pressure and therefore impedes drainage and increases varicocele size. Grade 2 or medium is palpable when standing and bearing down, though can be palpated without Valsalva maneuver. Grade 3 or large is visible on inspection alone. There's also subclinical, which is not palpable. The vein is larger than 3 mm on ultrasound, and there is Doppler reflux when patient is asked to do the Valsalva maneuver. In terms of variation, watch out for bilateral varicoceles, which occur in a third of varicocele patients. As varicoceles are usually left-sided, look out for isolated right-sided varicoceles. Evaluate the patient with an abdominal CT scan to look for possible retroperitoneal masses like inferior vena cava obstructions, renal cell carcinoma with IVC thrombus, or right renal vein thrombosis with clot propagation down the IVC, among other causes. So the reason that varicoceles tend to be more left-sided may be explained with the asymmetrical anatomical differences between the left and right testicular vein. The left testicular artery is longer and may be under higher pressure because it drains into the left renal vein, which is situated between the abdominal aorta and the superior mesenteric artery. Recall that this causes a nutcracker effect. Increased pressure may lead to dilatation and aberration of valvular leaflets in the testicular vein, thus allowing for retrograde flow towards the testes during standing. For physical exam, always start with vitals. Upon inspection, look for a bag of worms appearance that increases with standing or Valsalva maneuver. If you can directly observe the varicocele superficially, it is considered large or grade 3. Varicoceles do not transilluminate when you shine a light through the lesion. As mentioned, if a varicocele is present, it is almost always left-sided and extratesticular. Important palpation findings include a bag of worms deformity and absence of the vas deferens. Moreover, the testes on the side of the varicocele often lies horizontally. To identify small varicoceles, palpate the spermatic cord between the thumb and forefingers and ask the patient to do a Valsalva maneuver. These small varicoceles should disappear in recumbency. Conversely, moderately sized varicoceles can be identified by palpation without Valsalva. Although rarely done, you can also auscultate the scrotum to assess bowel sounds to rule out a hernia. When diagnosing varicoceles, scrotal ultrasound with high-resolution color flow Doppler is the diagnostic method of choice. However, it is not indicated for standard evaluation. Furthermore, check urinalysis results. Varicoceles usually have a negative urinalysis result. If fertility is worrisome, do a semen analysis twice. A CT abdomen is ordered to evaluate retroperitoneal pathology indicated by sudden onset of the varicocele, or single right-sided varicocele, or any varicocele that is not reducible in recumbency. Surgical management of varicocele is indicated by impaired sperm quality in infertile men, or men with testicular atrophy, or with pain or discomfort. It is important to note that a scrotal varicocele is the most amenable factor in men with poor semen quality. Furthermore, there is no solid evidence or established guidelines for treatment of varicoceles. Though if treatment is to be done, the preferred first-line surgical intervention is to ligate the gonadal vein to stop retrograde flow into the varicocele, either through an inguinal, subinguinal, lumbar, or laparoscopic approach. Moreover, percutaneous angiographic embolization of the internal spermatic vein is also an option. Conservative treatment with scrotal support and NSAIDs can be done for older men who no longer wish to have children and present with minor scrotal discomfort. Types of torsion include testicular torsion and torsion of testicular appendages. Testicular appendages include appendix testes and appendix epididymis, both of which are embryological remnants of the Mullerian and Wolffian ducts, respectively. These form connections to the tunica vaginalis, as you can see in this figure. Pathophysiology of testicular appendage torsion. These appendages can become acutely inflamed and cause scrotal pain. They're more gradual in onset than testicular torsion, with pain ranging from mild to severe. Torsion of appendages can lead to their infarction and necrosis, which is responsible for the blue dot sign on the scrotal skin, localized at the anterior superior aspect of the testes. Additionally, torsion of this sort can lead to reactive hydrocele, which can lead to the lesion transilluminating. The classic findings of testicular appendage torsion include subacute symptom onset with pain localized to the upper pole of testes, the cremasteric reflex still present unlike testicular torsion where it's lost, presence of the blue dot sign, and if reactive hydrocele forms, the lesion will transilluminate. If torsion of testicular appendages is confirmed, management is usually conservative with NSAIDs, ice, and rest. Pain may persist for weeks to months. However, if pain continues further, surgical exploration is considered. Moving on to testicular torsion, there are two types, intravaginal and extravaginal. Intravaginal torsion is due to abnormal structure and function of the gubernaculum testes, which fixes the testes to the tunica vaginalis. There is increased mobility of the testes within the tunica vaginalis. Extravaginal torsion is due to abnormal attachment of tunica vaginalis to scrotal wall, allowing both the testicle and the tunica vaginalis to twist together. This is associated with neonatal testicular torsion in the first 30 days of life. Torsion of testicle and its spermatic cord results in ischemia, which presents with acutely painful, tender, and swollen testes. The affected testicle is retracted upward into the scrotum, and the cremasteric reflex is almost always absent on the affected side. If torsion progresses without intervention, the scrotum turns erythematous and edema ensues. Within 4 to 6 hours of no intervention, testicular ischemia, infarction, and subsequent atrophy occur. This is why it's considered a urologic emergency. This figure demonstrates extravaginal testicular torsion, where both the tunica vaginalis and the encased testicle twist together, in which torsion of the spermatic cord leads to decreased blood supply. Important classical history findings of testicular torsion include patient age between 12 and 30. It can also occur at any age, occurring before birth and in neonates too. Patients typically present with sudden onset severe pain. If severe pain coming from the testicle itself, think about testicular torsion. If pain is coming from a specific anterior superior testicular pain, think of appendiceal torsion. There may be trauma or vigorous exercise preceding the pain, maybe nausea and vomiting, maybe previous episodes of intermittent pain indicating torsion or detorsion events, especially demonstrated in children who awake at night with scrotal pain that self-resolves. Testicular torsion is usually not associated with UTIs. Furthermore, testicular torsion is a clinical diagnosis, as this is a urologic emergency where you should be able to diagnose it early without waiting for tests. So the question is, how do you differentiate between testicular torsion and epididymoorchitis, and how are they similar? Since testicular torsion is a clinical diagnosis, sometimes it can be difficult to discern between the differential diagnoses. Both conditions clinically present with scrotal pain, tenderness, erythema, and swelling, but you must differentiate as management depends on the condition you rule in. You typically rely on Doppler ultrasound to differentiate if readily accessible. It'll show you a lack of flow in torsion, whereas in epididymoorchitis there will be increased flow or hyperemic testicle. Important physical findings suggestive of testicular torsion are a scrotum markedly painful on examination, significant testicular swelling, asymmetrical high-riding testes, absent cremasteric reflex, which you can assess by stroking or gently pinching the skin of the upper thigh while observing the ipsilateral testes, presence of a bell clapper deformity where the testes lies horizontally suspended in the tunica vaginalis by the spermatic cord, and the inability to transilluminate. In this image, we see a bell clapper deformity. Notice the horizontal lying testes. When there is a strong suspicion of an alternate diagnosis, lab testing can be used. Urinalysis and urine culture are done to rule out pyuria and bacteriuria. which would suggest epididymitis or infection. The urinalysis is usually negative for testicular torsion. Furthermore, CBC and urinalysis may show elevated white blood cells in patients with torsion. Imaging studies are not usually necessary when there is clinical suspicion of testicular torsion. If you're uncertain, color Doppler ultrasonography of the scrotum is usually used, which can be used in conjunction with the Valsalva maneuver to detect changes in blood flow and soft tissue abnormalities. Ultrasound findings suggestive of acute testicular torsion include absent or decreased blood flow to affected side, decreased flow velocity in the intratesticular arteries, and hypervascularity with a low resistance flow pattern after a partial torsion-detorsion event. The key point is, if ultrasound is not available and torsion is suspected, do not delay surgical evaluation and, if necessary, exploration. Urologic emergency due to the obstructed circulation that could lead to the loss of the testicle. Loss of a salvageable testes outweighs the disadvantage of a negative outcome in surgical exploration. Often, it is possible to detorse a testes during examination through gentle rotation away from midline like opening a book. Relief of pain indicates likely testicular torsion was the cause. Manual detorsion is performed if surgical intervention is not immediately available within 2 hours. It is possible for the testicular torsion to be rotated medially in the majority of cases, so pick up on the following to determine if detorsion is going well. Relief of pain, change in positioning of testes to one lower, shifting orientation from horizontal to longitudinal, and return of arterial pulsation detected through colored Doppler ultrasound study. Despite successful manual detorsion, it is necessary to do surgical exploration in order to stabilize the testicle to the scrotal wall, preventing recurrence. In terms of the surgical approach, if testicular torsion is clinically suspected and imaging is not available, prompt surgical exploration and intraoperative reduction of torsion is required. Always perform bilateral orchidopexy, another term for fixation of testicle in place with sutures, to ensure the affected and contralateral testicles do not retwist. Orchidopexy is done bilaterally because the gubernacular defects are usually bilateral. Furthermore, if there is a surgical intervention within 6 hours, the testicle is almost always salvageable. If it's between 6 and 12 hours, the testicle is salvageable about 85% of the time. And if it's over 12 hours, it is typically too late due to infarction. Orchiectomy is therefore required. Okay, we're almost done. The last topic to cover is testicular cancers. As with many cancers, testicular cancer has different categories, namely germ cell and non-germ cell derived. Germ cell cancers include seminoma, which occupies 35% of testicular cancers, and non-seminomas that occupy the rest, which are divided into embryonic cancers, teratomas, choriocarcinomas, and yolk sac tumors. Non-germ cell include sex cord or stromal tumors, mainly Leydig cell and Sertoli cell tumors. Generally, testicular cancers as a whole are intratesticular lesions. It is the most common solid tumor in men between ages 18 and 40, though relatively rare. The risk of diagnosis is 5 times more common in white men versus black men. Highly treatable when detected early. Lesions involving the testicle are urgent conditions. Any solid intratesticular lesion has to be considered a malignancy until proven otherwise. Approximately 90% of these lesions are cancer. Classic history findings include, most typically, painless enlargement of the scrotum in either testicle. Symptoms are more of a chronic nature. A sensation of heaviness in the scrotum, pain or dull aches, and back pain may be associated. Patients may report a sudden collection of fluid in scrotum. There is usually a delay in diagnosis for 4 to 6 months, so occasionally a patient can present with metastases. Furthermore, risk factors for testicular cancers are a history of cryptorchidism, which are undescended testicles, or testicular atrophy, family history, and HIV infection. Atypical presentations may include acute scrotal pain secondary to hemorrhage and infarction if the testicular cancer is a rapidly growing germ cell tumor, more common in choriocarcinoma. Testicular cancers may be associated with a reactive hydrocele that can transilluminate. Some patients may have gynecomastia, which is an enlargement or tenderness of the breast tissue. Here's another question. If you clinically suspect testicular cancer, how do you biopsy it? And the answer is never biopsy testicular mass that is concerning for malignancies. Testes cancer spread through retroperitoneal lymphatic channels. Biopsy may seed the cancer into the scrotal skin, which drains through the inguinal lymphatic channels. Testicular lymphatic channels drain to the para-aortic lymph node. Therefore, a biopsy through the scrotal incision may spread the cancer in an iatrogenic fashion. Important physical findings include any solid intratesticular lesion, which is considered testicular cancer and requires urgent attention. Intrascrotal malignancies are usually firm, non-tender masses. Both testicles must be examined because 5% of cases can occur on the opposite side as well. This lesion does not transilluminate. Additionally, check for abdominal lymphadenopathy or masses. So for lab investigation, remember to never biopsy a testicular mass lesion through a scrotal incision because it can cause the cancer to spread through inappropriate lymphatic channels. Initial investigation of a testicular mass is to look for tumor markers in blood, such as alpha-fetoprotein, beta-HCG, and LDH. The initial preferred test to diagnose testicular cancer is scrotal ultrasound. However, there are limitations as many conditions mimic neoplasia on ultrasound, including inflammation, hematoma, infarcts, fibrosis, and tubular ectasia. Furthermore, MRIs can be used to differentiate between benign and malignant lesions if ultrasound is equivocal, or shows microcalcification on the surface of the testes. Imaging can also be used to determine the extent of spread, prognosis after treatment, and signs of recurrence, with chest x-ray, CT, MRI, bone scan. Testicular cancers have a staging system. Simply put, staging is divided into one of three stages. Stage 1 means cancer is confined to the testicle. Stage 2 involves retroperitoneal lymph node metastases, and Stage 3 involves visceral metastases. Surgical management of testicular cancers include preoperative preparation, where many patients will require a CT scan of the abdomen and pelvis, and a chest x-ray or a CT chest to rule out metastases. Surgical management is usually done for early stage testicular cancer, which has excellent prognosis for patients, hence patient education about self-screening is necessary. Surgeries include radical inguinal orchiectomy, which is a surgical removal of the testicle through an inguinal incision. The testicle and tumor, along with the spermatic cord containing the lymph channels and blood supply, possible pathways for spread, are removed, which prevents further metastases. Early in the surgery, vessels are tied off to minimize the chance of cancer cell spread. The entire specimen is sent to pathology, who then describes the type and extent of the cancer. Rarely, if diagnosis is uncertain, the surgeon will withdraw the testicle from the scrotum through an inguinal incision without severing the spermatic cord. The testicle is examined for suspicious areas, and biopsies are taken and given to pathology to be looked at right away. If cancer is confirmed, then the surgeon may proceed with the orchiectomy. If cancer is ruled out, then tumor is removed from the testicle, which is replaced back in the scrotal sac. Overall, testicular cancer are the most curable of all solid neoplasms. There's almost a 100% cure rate for low-stage cancer, which is usually managed with radical orchiectomy and surveillance of the retroperitoneum. However, indications for non-operative management is advanced cancer, like stage 2 and 3, where treatment may be more complex but usually involves chemotherapy and for some patients involves further surgery, specifically retroperitoneal lymph node dissection. Chemotherapy has evolved to reduce patient morbidity while maintaining efficacy. So overall summary. Classifying the conditions according to whether it is intra or extratesticular. Benign conditions are more common than malignant. However, masses of testicles must be considered malignant. Testicular torsion is a urologic emergency. Do not delay surgical exploration. Testicular cancer, when caught early, is very curable. If any doubt, get scrotal ultrasound. Under no circumstances should you biopsy a testicle through a scrotal incision.